العامين وأطباء الحضانة وأطباء القلب لأهمية اكتشاف هذا المرض مبكرا ثم تحويله إلى المراكز المختصة في طرق العلاج ومنع التشنجات المستعصية قبل حدوثها والتي سوف تؤثر على النمو الطفل. We'd like to start our first TS Complex Comprehensive Forum, and in the beginning I would like to thank all the organizers who accepted all the organizers for their effort, and special thanks to Dr. Daad Aswad for her effort to bring this forum to you. And there is no word to say enough to thank enough Dr. Faisal Atebi and the Saudi Epilepsy Society for their support, and also the sponsorship also shared in this forum. I would like also to thank the president of the Saudi Pediatric Neurosociety, Dr. Fahad Al-Bashiri, who is also a member of and one of the founder of the Asrar TSC support group. And I would like to thank all the speakers who donated their time and their effort to bring up this forum to you, and also the moderator and the event, EG event conference group, and also the sponsor Hikma and Levanova. We are going to start in like after 5 minutes from now. The first session will be chaired by my colleague, Dr. Amal Qasimi, who is a consultant pediatric neurologist, epileptologist. She is the head of the pediatric neurology department at King Saud Medical City in Riyadh. She got her training and fellowship in neurology and epilepsy in Canada, London, Ontario. And we'll leave you now with the video about the Asrar TSC support group. And thank you.
أسرار طفلة مولودة جميلة انتظرها والداها بشوق ولهفة طيلة 9 شهور، لكن الفرحة لم تكتمل، لأن أسرار واحدة من آلاف الأطفال المصابين بمرض التصلب الحدبي المتعدد. ستعيش أسرار كل عمرها في صراع مستمر مع الصرع المستعصي واضطرابات سلوكية وعقلية ومشاكل بالقلب والكلى والرئتين والبصر والجلد. وتشير الدراسات إلى أن واحدا من كل 5000 مولود من حديثي الولادة سنويا مهدد بالإصابة بمرض التصلب الحدبي المتعدد. ومع تزايد المصابين بالمرض جاءت فكرة إنشاء جمعية أسرار التصلب الحدبي المتعدد لتساند هذه الفئة من خلال حزمة من الأهداف: 1. تقديم الدعم للمرضى. 2. توفير العلاج والأجهزة الطبية. 3. إجراء العمليات الجراحية. 4. توعية المجتمع وتأهيل المصابين وذويهم للتعايش مع المرض. 5. دعم الدراسات عن المرض. 6. توعية المجتمع بالمرض. جمعية أسرار التصلب الحدبي المتعدد بدعمكم تحقق أهدافها. أسرار أسرار طفلة مولودة جميلة انتظرها والداها بشوق ولهفة طيلة 9 شهور، لكن الفرحة لم تكتمل، لأن أسرار واحدة من آلاف الأطفال المصابين بمرض التصلب الحدبي المتعدد. ستعيش أسرار كل عمرها في صراع مستمر مع الصرع المستعصي واضطرابات سلوكية وعقلية ومشاكل بالقلب والكلى والرئتين والبصر والجلد. وتشير الدراسات إلى أن واحدا من كل 5000 مولود من حديثي الولادة سنويا مهدد بالإصابة بمرض التصلب الحدبي المتعدد. ومع تزايد المصابين بالمرض جاءت فكرة إنشاء جمعية أسرار التصلب الحدبي المتعدد لتساند الفئة من خلال حزمة من الأهداف: 1. تقديم الدعم للمرضى. 2. توفير العلاج والأجهزة الطبية. 3. إجراء العمليات الجراحية. 4. توعية المجتمع وتأهيل المصابين وذويهم للتعايش مع المرض. 5. دعم الدراسات عن المرض. 6. توعية المجتمع بالمرض. جمعية أسرار التصلب الحدبي المتعدد، بدعمكم تحقق أهدافها. أسرار طفلة مولودة جميلة انتظرها والداها بشوق ولهفة طيلة 9 شهور، لكن الفرحة لم تكتمل، لأن أسرار واحدة من آلاف الأطفال المصابين بمرض التصلب الحدبي المتعدد. ستعيش أسرار كل عمرها في صراع مستمر مع الصرع المستعصي واضطرابات سلوكية وعقلية ومشاكل بالقلب والكلى والرئتين والبصر والجلد. وتشير الدراسات إلى أن واحدا من كل 5000 مولود من حديثي الولادة سنويا مهدد بالإصابة بمرض التصلب الحدبي المتعدد. ومع تزايد المصابين بالمرض، جاءت فكرة إنشاء جمعية أسرار التصلب الحدبي المتعدد لتساند هذه الفئة من خلال حزمة من الأهداف: 1. تقديم الدعم للمرضى. 2. توفير العلاج والأجهزة الطبية. 3. إجراء العمليات الجراحية. 4. توعية المجتمع وتأهيل المصابين وذويهم للتعايش مع المرض. 5. دعم الدراسات عن المرض. 6. توعية المجتمع بالمرض. جمعية أسرار التصلب الحدبي المتعدد، بدعمكم تحقق أهدافها. أسرار طفلة مولودة جميلة انتظرها والداها بشوق ولهفة طيلة 9 شهور، لكن الفرحة لم تكتمل، لأن أسرار واحدة من آلاف الأطفال المصابين بمرض التصلب الحدبي المتعدد. ستعيش أسرار كل عمرها في صراع مستمر مع الصرع المستعصي واضطرابات سلوكية وعقلية ومشاكل بالقلب والكلى والرئتين والبصر والجلد. وتشير الدراسات إلى أن واحدا من كل 5000 مولود من حديثي الولادة سنويا مهدد بالإصابة بمرض التصلب الحدبي المتعدد. ومع تزايد المصابين بالمرض، جاءت فكرة إنشاء جمعية أسرار التصلب الحدبي المتعدد لتساند هذه الفئة من خلال حزمة من الأهداف: 1. تقديم الدعم للمرضى. 2. توفير العلاج والأجهزة الطبية. 3. إجراء العمليات الجراحية. 4. توعية المجتمع وتأهيل المصابين وذويهم للتعايش مع المرض. 5. دعم الدراسات عن المرض. 6. توعية المجتمع بالمرض. جمعية أسرار التصلب الحدبي المتعدد، بدعمكم تحقق أهدافها. أسرار طفلة مولودة جميلة انتظرها والداها بشوق ولهفة طيلة 9 شهور، لكن الفرحة لم تكتمل، لأن أسرار واحدة من آلاف الأطفال المصابين بمرض التصلب الحدبي المتعدد. ستعيش أسرار كل عمرها في صراع مستمر مع الصرع المستعصي واضطرابات سلوكية وعقلية ومشاكل بالقلب والكلى والرئتين والبصر والجلد. وتشير الدراسات إلى أن واحدا من كل 5000 مولود من حديثي الولادة سنويا مهدد بالإصابة بمرض التصلب الحدبي المتعدد. ومع تزايد المصابين بالمرض، جاءت فكرة إنشاء جمعية أسرار التصلب الحدبي المتعدد لتساند هذه الفئة من خلال حزمة من الأهداف: 1. تقديم الدعم للمرضى. 2. توفير العلاج والأجهزة الطبية. 3. إجراء العمليات الجراحية. 4. توعية المجتمع وتأهيل المصابين وذويهم للتعايش مع المرض. 5. دعم الدراسات عن المرض. 6. توعية المجتمع بالمرض. جمعية أسرار التصلب الحدبي المتعدد بدعمكم تحقق أهدافها. أسرار طفلة مولودة جميلة انتظرها والداها بشوق ولهفة طيلة 9 شهور، لكن الفرحة لم تكتمل، لأن أسرار واحدة من آلاف الأطفال المصابين بمرض التصلب الحدبي المتعدد. ستعيش أسرار كل عمرها في صراع مستمر مع الصرع المستعصي واضطرابات سلوكية وعقلية ومشاكل بالقلب والكلى والرئتين والبصر والجلد. وتشير الدراسات إلى أن واحدا من كل 5000 مولود من حديثي الولادة سنويا مهدد بالإصابة بمرض التصلب الحدبي المتعدد. ومع تزايد المصابين بالمرض جاءت فكرة إنشاء جمعية أسرار التصلب الحدبي المتعدد لتساند هذه الفئة من خلال حزمة من الأهداف: 1. تقديم الدعم للمرضى. 2. توفير العلاج والأجهزة الطبية. 3. إجراء العمليات الجراحية. 4. توعية المجتمع وتأهيل المصابين وذويهم للتعايش مع المرض. 5. دعم الدراسات عن المرض. 6. توعية المجتمع بالمرض. جمعية أسرار التصلب الحدبي المتعدد بدعمكم تحقق أهدافها.
I don't like to just be.
Okay, Assalamu alaikum. So you can start now?
Yes.
Okay. Assalamu alaikum, everyone. It is a pleasure for me to be a part of this actually workshop. It seemed to be interesting topics to be running this day. First of all, I would like to thank Dr. Ali Al-Ataibi for these invitations and the organizing committee for giving me the chance to be a part of this interesting workshop. It's my pleasure to introduce the first speaker. The first speaker is Dr. Samir Al-Mahmadi. He's currently a pediatric neurology consultant at Prince Sultan Military Hospital. After he completing his Saudi board of pediatric neurology, he did his fellowship training at SICKES Toronto, and then he completed his training for the research fellowship. Welcome, Dr. Samir. The mic is yours.
Yeah, thank you so much, Dr. Amal, and thanks for the organizing committee. Today, I will just give an overview about the tuberous sclerosis complex disease and the genetic heterogeneity, and the best things to go with cases. So the first case I just hear about from Dr. Afnan. She has an interesting family in which the father, 36-year-old man with tuberous sclerosis, he has skin manifestation. He's in well-controlled epilepsy in one medication. He's an engineer with thriving career. And he has a 2-year-old son with tuberous sclerosis. The second case is a 6-year-old boy with tuberous sclerosis. He has cardiac rhabdomyomas, variable organ involvement, but he has it seemed like normal intellectual functioning with fair school performance, and he also lacked the major part of cutaneous manifestation of the disease. And then we have the typical case, what we saw in the clinic. What we see in the clinic is those patients with severe disease, and this is an 8-year-old girl with tuberous sclerosis, severe global developmental delay, intractable epilepsy despite multiple anti-epileptic medication, and clear skin manifestation. So if you go through those 3 cases, we find there's slight differences in the clinical presentation and with variability. And so hopefully this mainly will be our objective. So I'll go over a few about the tuberous sclerosis and why those differences between the patient and from genetic perspective, and then briefly about genetic testing and counseling. So tuberous sclerosis is a rare neurocutaneous diseases. It has multi-system involvement in terms of growth of benign tumors and hematomatous lesion that has wide, diverse, and debilitating clinical sign. As in the video, the prevalence is 1 in 20,000, with the incidence of from one in every 6,000 to 10,000. There is no clear differences between ethnic groups or genders, and unfortunately, there is no clear studies within the kingdoms. However, like in UK, they said there's 10 babies born every month with tuberous sclerosis, and there is estimated the total population of tuberous sclerosis around the world to be 1 million. 1 million. This is just to give you a sense of the clinical manifestation. Dr. Rashada will come to this in more detail, but you can see there's quite like almost every organ in the body is involved with different signs and symptoms and different manifestations. It's really interesting, like the disease evolves with time, and usually we have different presentation at different age in terms of age and presentations. So in summary, like tuberous sclerosis causes highly variable multisystem growth of benign tumors and other hematomas, and there is wide diverse clinical presentation, as you will see in the next lectures. So why there is variability? From genetic perspective, tuberous sclerosis is autosomal dominant. So if one of the, like in number one, if one of the parents has disease, usually he'll less than 50% of his offspring across all generation. However, if you have new mutation, usually also the new mutation will pass it to his offspring. So it's autosomal dominant. It's mainly involved about two genes, which everybody know, like we have TSC1 gene and TS2 gene. De novo mutation account for almost like 80% in some studies. Usually TS2 mutation present 4 times more in those cases. However, in familial cases, there's equal distribution between TSC1 and TSC2. There's few cases, less than 10%, and variable between the study, but with no mutation identified in those cases, and we will come to this why we are not able to identify the genes. Usually they refer to them the NMI, which is no mutation identified. So again, it's highly variable expression across diseases, differ in terms of onset, severity, and different signs and symptoms. Usually there is no effect of paternal or maternal age or the birth of order in the disease phenotype. Just to give you a sense, like this is the mTOR pathway, which is the main pathogenesis of tuberous sclerosis complex. So TSC1 and TS2 make combined, they make TSC complex, which main function is in working on mTOR. It's like a brake for the mTOR, it's inhibited. So if there is any dysregulation or any inhibition for the complex dysfunction, this lead to release the mTOR, leading to different abnormality, mainly cellular, leading to overall cellular growth. So you have apoptosis, protein translation, and overall result in increased cell growth. So why we have patients with different presentations? So the main variability come from multiple causes, mainly 3 of them. There is differences between TSC1, TS3 genes, the variety of mutations found in those. Then we have somatic mosaicism, and then the 2-hit hypothesis. So I'll come to this one by one, which is the main bulk of the presentation. So TSC1 mainly located in chromosome 9. It's mainly encoded for hamartin. It's composed of around 23 exons. This is how the exon look like. The gene look like, and you can see there's huge variability and in terms of the number of variants and what's the abnormality. So if you see to this pie chart, most of the mutation is insertion or deletion, followed by nonsense, then a missense. And if you go to the side with the location of those abnormalities, if you go to the number of exon, as we know, we have like 23 exon. The number of variant per exon is mainly affected exon number 15, and in terms of variants per nucleotide, it's mainly in exon 8. So we have different mutations and different loads of different abnormalities. So we have several different types of mutations. Large deletion is non-distant. So the main thing is a small deletion or insertion. So this in contrast to TSC2, the missense mutation are very rare in TSC1. And usually in patients without a family history of the disease, the majority of mutation mainly in TSC2. So in TSC2, it's located in chromosome 16. It's encoded for tuberin, and it has around like 42 exons. And again, if we go to the variation, you can see like insertion deletion around like 30%. Almost like there's equal distribution between different type of mutation. Again, the variance per exon or per nucleotide is most variable across all the exons. So the TSC2 function usually in normal brain developments and usually in withdrawal of the normal cardiocytes from the cell during the termination. So in that time, we have more benign cardiac tumors, rhabdomyoma, that observe in tuberous sclerosis. As with TSC1, the majority of mutation are loss of function mutations. Again, larger deletion rearrangement are more common. And in contrast, usually 25% are missense mutations. So this variability in the mutation in these two genes create like differences in not even in the clinical clinical part, but also at pathological levels. And this is a nice study was done in China, and they analyzed the genotype and phenotype analysis of children with tuberous sclerosis. And it's really interesting. So they compare first tuberous sclerosis 1 to tuberous sclerosis 2, and with patient with no mutation identified. And if you go to epilepsy, there's quite differences between the three groups. So in terms of epilepsy, we have more patients, like more significant in patients with tuberous sclerosis 2. Again, if you go to the subependymal or cortical tubers, you can see there's some differences between the two groups. This is between the gene as overall, between TSC1, TSC2, and no mutation identified. If you go to sub-analysis of different mutation within each gene, also you find huge differences between those patients. So if you go for epilepsy, for example, some mutation has like 100%. And some will have less than that. It's really interesting. If you go to the group of TSC2, you can find there's some mutation, like all patients will have seizures, and in some mutation, like only 50% will have epilepsy. So there's huge variation between the genes themselves and variation within the gene. This is another study. They just collect like how different study and which side has which side of the mutation, and you can see there's quite different variability between different type of variations. It's really nice. Like if you have your own patients and you can identify the variants, you can look in the literature and see what's their percentage of having different manifestations. So the second part is somatic mosaicism. So just in brief, so most of the time in a person with genetic mutation, let's see tuberous sclerosis, one copy of the gene is changed in all the cell bodies. Sometimes an individual can have only some cell with no change and some cell with gene change. So this is the term, what we call mosaicism. So if your skin has the gene, then you will have skin manifestation. If other parts of your doesn't have the gene, the manifestation will not happen. It's the same. If your kidney cells have the gene, then you will have the gene, the kidney findings. If your skin doesn't have it, then you will not have the manifestation. So it depends on where as abnormalities. The third part is the two-hit hypothesis. So why do individual tuberous sclerosis finding usually have it over their lifetime rather than being born with all these manifestation. And this is Hebels can explain it in terms like tuberous sclerosis work in cell like a break. So you have if both copy working fine, then the twisted will have a break, and usually you have control over the mTOR pathway. If the patient loses one, then he has only one set of breaks working, and if he loses both, then we have complete failure, and usually the manifestation will develop. This is mainly the hypothesis. So patient may have first hit mutation and tumor suppressor gene, the second hit with wild type, and then you have complete loss of function. And if you go over the study, they said like around the patient, usually they have 65% will have 2 hits, and one like third will have this is mainly for research purposes. And if you go to the genetic testing, why we can't find all genetic variants? So sometimes we have patients still like in some studies, say 3% to 10%. We will not find any mutation. Usually, this is usually either because most of the time we take like blood samples and we don't take body cells. So usually we cannot identify those mutation in the introns. It's sometimes unclear to us what disease-causing variant in the promoter look like, and sometimes we cannot test every cell in the body, especially in terms of mosaics. So if you have a parent and they want to know what's the risk for the family members, so a parents of proband, if a patient has a de novo pathological pathogenic variant, then the recurrence is 1 to 2%. It's slightly higher than the general populations. If the patient is a proband with heterozygous pathogenic type, then we have 50% risk. And if the patient has, again, mosaic pathogenic variants, this will be a little bit tricky to calculate, but most of them, the recurrence, they assume it to be 50%, should be provided with prenatal, usually, testing. If other family member is affected, usually the risk of the family members depend on the status of the proband parent. If the parent is affected, then it's 50%. As it's familial, if the parent is not affected, then they have like around like 1% to 2% risk. So if the parents plan for families, then the pathogenic, then there's two parts. If the patient two way. Either if we know like the pathogenic variant and we identify it, then we resort to prenatal testing or pre-implantation genetic testing for pregnancy at risk of If the pathogenic variant has not been identified, usually we offer the patient monitoring, usually prenatal, mainly with ultrasound, but usually prefer to be done at a tertiary center with expertise in tuberous sclerosis. So in summary, it's autosomal dominance. There's wide phenotypic variability of clinical presentation, as we discussed it to different genetic variability, and usually approximately 2/3 are sporadic, and the result apparent spontaneous. Thank you so much. I hope I cover everything at the time.
Thank you, Dr. Samir, for this informative, excellent lecture. I think we'll keep the questions later, so we can present the second speaker. Thank you, Dr. Samir. So the second speaker is Dr. Rashada Shafi. She's a consultant pediatric neurologist and epileptologist and EEG in Prince Sultan Hospital. She did her Saudi board in pediatric neurology in Prince Sultan Military Medical City, and then she finished her fellowship in pediatric epilepsy and EEG at the Hospital of Sick Kids at University of Toronto. Welcome, Dr. Rashada. The mic is yours.
Thank you, the organizing committee. Thank you, Dr. Amal. Can you see my slide?
No slide. You have to, I think, to do share. Yeah, now it's clear.
Okay. Bismillah ar-Rahman ar-Rahim. So, as Dr. Samin mentioned earlier, this is an autosomal dominant disease that affecting multi-system, and it is characterized by benign tumors with very wide variability in the presentation that can cross the lifetime. It is not uncommon, but can go unrecognized, given that the clinical manifestation varied in age of onset, the extent of systemic involvement, as well as the severity. These manifestations associated with severe morbidity and potentially death, so early diagnosis and lifelong surveillance management are really crucial. Among medical subspecialties, the pediatric neurologist is often responsible for making the initial diagnosis when the affected individual presented with infantile spasm or any other type of epilepsy syndrome. Talking about history, back in 1835, long time ago, a French dermatologist, he described in his atlas a disease where there is a small vascular papules distributed over the nose and around the mouth. However, he did not mention any medical association with this skin disorder. Later on in 1862, a German physician, he worked in a pathology lab. He described a newborn who died a few seconds after birth due to multiple cardiac myotoma. Besides that, the brain autopsy showed subsclerotic areas. 18 years later, in 1880, Bromville, a French neurologist, added more important clinical neurological details, and he described the brain pathology, the same what we are using. It's tuberous sclerosis. Afterward, a German pediatric neurologist, his name is Vogt, it is well known, who established the diagnostic criteria for TSC, which is a triad of epilepsy, mental retardation, and adenomaceration. This triad was used for 60 years until a researcher called Gomes, that I will come later, he found that only 1/3 of the patient of TSC have only these three symptoms. This is Dr. Gomes, that he really did a turn pointing in understanding TSC in 1979 when he published a first edition of tuberous sclerosis. It was a very first comprehensive source of information about TSC, and it was a contribution not only from his side, it's also from a cardiologist, nephrologist, and other specialties. And he first published the diagnostic criteria in his second edition. Subsequently, in 1998, the criteria being revised, and by that time, it also revised in 2012 and again last year. So our understanding of clinical feature of TSC really improved. Mutation could be identified at least before it was in research setting, now in clinical basis, and making or validate the diagnostic significance of TSC manifestation. So the new diagnostic clinical criteria in 2021, last year, have only 2 changes from the previous version. Now it have 11 major features and 7 minor features. The previous major clinical diagnosis criteria of cortical dysplasia changed to multiple cortical tubers and radial migration lines, as this is really non-specific and potentially confusing to the clinician. Besides that, a dermatology and dental working group recommended to adding back the minor criteria, which is sclerotic bone, which have been eliminated in 2012 clinical criteria. So this is the paper that last year released, which have the updated diagnostic criteria. I recommend everyone to review it. Seeing this nice paper that done in the UK, where they studied the clinical profile of tuberous sclerosis complex of a cohort of more than 300 patients, they found like around 7 system is involved in the TSC. And the most system involved are nervous system, psychiatry and dermatology. And you can see that the lines, the connected line, the width of each line reflects the frequency of the patient that have manifestation involving both organs. Sorry. Coming to TUSCA, it's a tuberous sclerosis registry to increase disease awareness, published in 2017. It is a very largest case series to see up to date. It's involved more than 170 centers from 31 countries. And as you can see, more than 50% of these cases, it's from neuropediatric clinics. From TISCA paper, as also Samir been mentioned, it showed the prevalence of the manifestation separately. For example, in the brain, the most common and prevalent disease, it's cortical tuberous, followed by subependymal nodules, epilepsy affecting 80% of the cases, and up to 70% it's started below the age of 2. If you see in the right lower quadrant, the skin manifestation, the hypomelanotic macules affecting 66%, facial angiomas around 60%. Again, as Samir mentioned earlier, it have a really distinct pattern of age-related emergence and prevalence of TSC manifestation. For example, the hypomelanotic macules, subependymal nodules, cortical tuberous, and cardiac rhabdomyomas reported in less than 2 years of age. In another hand, the renal myolipomas, facial angiofibromas, Guillain-Barré, it's increased in adulthood. We'll start with the clinical manifestation of the skin. In this nice paper, they go through each one of them. So we'll start with hypomelanotic macule, or they call it ash leaf. So it is a white spot, can distributed any part of the body and enhanced with wood lamp. And it's seen up to 97% of the patient. Second, facial angiomyomas. It is pink papules, mainly affecting centrofacial area, sparing the upper lips, affecting 74%. Molluscum denidulum, it is, the Chaguin patches. It is slightly elevated patches over the dorsal part of the body, mainly over the lumbosacral area. It is found in around 50% of the patient. Molluscum, it's meaning the skin tag, and it's seen around 20% of the cases. Forehead fibrous flake, it is a yellowish flake over the forehead or scalp, can be seen in any age, and it's around 18%. Periangual or subangual fibromas are skin reddish nodules seen over the lateral nerve groove, and it's non-traumatic, should be non-traumatic, and present usually at puberty, and it's around 15%. And the least common of them, it's the confetti, like macules. It is very small, white spot, and usually seen in the second decade of life, and it's around less than 3%. Less frequent acral lesions, subungual red comet, splinter hemorrhages, longitudinal white streak,